Welcome to February's Resident Corner for the Society for Surgery of the Alimentary Tract. My name is Dr. Michael House, and I am an Associate Professor in the Department of Surgery at Indiana University. My clinical practice is focused on surgical oncology and hepatopancreatobiliary surgery. During this presentation, I will discuss the clinical productivity targets which will factor into your clinical salary and level of resources for clinical and administrative support. This month's Resident Corner continues a theme which has been presented to you over the past 4 months. That is, how do you make the transition into full-time practice after training, both residency training and fellowship training? This presentation will focus mainly on the clinical responsibilities that will be expected from a full-time faculty member within an academic health center. There are roughly 48,000 practicing surgeons in the United States, and the majority, or roughly 75% of these surgeons in 2014, were either hospital employees or had practices which were directly affiliated with a hospital or healthcare system. Based on national salary data, the median salary in 2013 for a general surgeon working in an academic health center was $243,000, with a range of $100,000 to $350,000 each year. An additional median bonus income of $30,000 was reported for either incentivized additional clinical duties or administrative roles. Most surgeons affiliated with an academic health center will have expectations and often mandates to participate in medical student, resident, and fellow training and education. Protected time to carry out these duties is usually not declared in a full-time faculty or employee contract, but a portion of your salary will be derived, either directly or indirectly, from such activities. For those of you who are pursuing a career invested in scientific or clinical research, protected time with a guaranteed salary of at least 40% of an average work week schedule should be established. While most new hires will start with a guaranteed contracted salary for the first 2 to 3 years, there will be an expectation to meet certain clinical work thresholds. Clinical salary is based on clinical workload, which is largely scaled according to Medicare's Relative Value Units, or RVUs, which measure the relative resources associated with a physician's work. That is, the time and skill required for a procedure or for evaluating a patient. Practice expenses, that is, your staff time and cost of maintaining an office, and associated malpractice expenses. The RVUs compare the resources required for one service to those for other services. The RBRVS tends to provide lower relative values for surgical and other technical procedures and higher relative values for evaluation and management services in order to promote physicians and surgeons to hold clinical office hours and to see patients on a regular basis. This table lists the median RVUs for physicians and surgeons employed directly by a hospital or health system in the United States. Geographic and practice type, that is, whether you're practicing in an academic or private setting, will reflect variations, but these figures will not vary by much. You can access the median RVUs for a general or specialized surgeon in a specific region where you are seeking position. I recommend that you reference appropriate tables within your region when you negotiate your first contract with regards to salary and clinical workload expectations. Using the median RVU threshold can help you lower your expected individualized threshold when you are negotiating protected time for research and teaching duties. For example, if you're seeking 50% protected time for academic pursuits, this should translate into a lowering of your work RVU threshold by 50% with no direct influence or effect on your base salary. This table lists the median compensation in dollars per RVU for each physician description. This is averaged across practice descriptions, but in general these figures reflect private practice compensation for services for Medicare recipients. Those of you who are seeking academic positions should reference tables adjusted for health system employees in specific geographic regions. Most of this information and pertinent nationwide comparison tables can be found easily on the web. This concludes this month's SSAT Residence Corner, which is intended to provide you with generalized information for negotiating your first contract as you transition into full-time practice. Understanding clinical productivity targets will allow you to structure your early career within an academic or private practice setting. Remember, knowledge is power, especially when it comes to negotiating your first contract.